Hello everyone, welcome to our next generation NCLEX RN review session. Today we're diving into an unfolding case scenario on acute pancreatitis, and this is designed to sharpen your clinical judgment skills using the NCSBN's clinical judgment measurement model framework. And we'll walk through a series of test items to help you master critical concepts and medication safety. Let's get started.
Before moving ahead, I have some exciting news for you. If you are determined to pass the NCLEX within a week or a month, then your best option is to enroll in our complete online NCLEX review crash course right now. This course is a comprehensive all-in-one solution, a guaranteed shortcut, and a proven method to pass. Over the last 5 years, more than 5,000 students have successfully cleared their NCLEX exams using this course with an impressive 99% passing rate. Here's what you'll get: 100-hour animated mini crash course, ideal for those who have limited time and want to pass in just 1 week. 300-hour comprehensive recorded lectures covering 300 high-yield NCLEX topics that the exam loves to test. 5,000 real NCLEX questions. Practice with actual past exam questions for better preparation. 15 full-length practice tests, including CAT simulation. Feel confident before your real exam day. Exclusive NCLEX ebook, the ultimate guide you need to pass. 1 year full access. Study anytime, anywhere at your own pace. This is a limited time offer. Enroll now to grab 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. All right, now let's dive into the topic.
Here's our first item here. This is a matrix multiple choice, and the case scenario says a 38-year-old male presents to the emergency department at 4 a.m. on day 1 with suspected acute pancreatitis. The admission data includes a chief complaint of severe epigastric pain, suspected acute pancreatitis, arrived around 4 a.m., and mode of arrival via the EMS. And the initial complaints included epigastric pain, 10 out of 10 per numeric pain rating scale, radiating to the back, nausea, vomiting times 3 days, weakness, dizziness. At the moment, pain level is around 10 out of 10. It's characterized as sharp epigastric pain. Initial interventions included 18-gauge IV access placement times 2, oxygen 2 liters per minute via nasal cannula, and place the patient on NPO. For the medical history, patient does not have any known allergies, has history of alcohol use disorder for about 12 to 15 drinks per day times 15 years, with type 2 diabetes with A1C of 8.9%. His past surgical history included appendectomy back in 2010, has a prescription for metformin 500 milligrams twice a day, and he is non-compliant. He is a smoker with 10-pack years of history. He is a construction worker, lives with the wife, and family history included alcoholism on his father's side. Mother has hypertension. Let's move along with the rest of the medical record here. These are the laboratory tests with amylase of 360, lipase 190, lactate 4.0, glucose 240, creatinine of 1.3, potassium of 2.4, calcium 7.8, magnesium 1.4, white blood cell count of 17,000, and platelet count of 100,000, and lactic dehydrogenase of 400, and AST 300. And I want you to pay attention to the reference range on the right side of the table. And the following diagnostic tests are abdominal ultrasound showing pancreatic edema, no gallstones, no pseudocyst. Chest x-ray showed clear lung fields, no pleural effusion. Abdominal exam, patient's abdomen is tender, distended, with hypoactive bowel sounds, with a Ranson score of 4, and this included the following: with a white blood cell count of 16,000, glucose being higher than 200 milligrams per deciliter, and the lactate over 4, and the age less than 55. Right. Let's move on to our next section of the medical record. We have the emergency department nurse's progress notes. It says around 4:10, patient arrived via EMS with complaints of severe epigastric pain, 10 out of 10, nausea, vomiting times 3 days, weak, dizzy, pale, diaphoretic, lethargic, blood pressure of 64/42, heart rate of 132, thready, respirations 28 per minute, saturation of 90 on room air, temperature of 100.9 degrees Fahrenheit. Telemetry showed sinus tachycardia, and we have corrected QT interval of 440 millisecond, no ectopy, lactated ringer solution, 2 liters of bolus via 18 gauge IV in the right arm started. Blood pressure now 84/54, and saturation of 93 on 2 liters per minute, nasal cannula, Foley catheter inserted per order, urine output 5 mL per hour, dark amber. Pain unchanged at 10/10, potassium and magnesium replacement ordered and being prepared. Telemetry monitoring ongoing, wife at bedside, anxious. All right, let's get into the next section of our medical record. We have the emergency department healthcare provider orders, entered around 4:30. It said lactated ringers, 2 liters IV bolus over 1 hour, repeat times 1 if blood pressure is less than 90/60. Lactated ringers IV maintenance at 300 mL per hour, titrate to urinary output greater than 30 mL per hour. Potassium chloride 40 milliequivalents IV in 500 mL in 0.9% sodium chloride over 4 hours. Recheck potassium in 6 hours. Magnesium sulfate 2 grams IV over 1 hour. Ondansetron 4 milligrams IV every 6 hours. PRN nausea. Oxygen 2 liters per minute nasal cannula. Vital signs every 15 minutes. Stat complete blood count and comprehensive metabolic panel, amylase, lipase, lactate, NPO status, hydromorphone 1 milligram IV every 4 hours, PRN for pain greater than 5 out of 10, consult for gastroenterology, abdominal ultrasound, abdominal CT with contrast once, lactated ringers IV 2 liters bolus, enoxaparin 40 milligrams subcutaneously daily for DVT prophylaxis. Insert Foley catheter to monitor urine output. Maintain closed drainage system. You can pause the video right now if you want to go back into the previous boxes for the medical record, so you can really capture those important details there. Now, what are we doing here? Well, we are going to answer this question. This is a matrix multiple choice, and it says select one descriptor, whether it's appropriate, inappropriate for each intervention. Select only one response per row, and we have the table. I want you to pay attention to each row. So what do you think about the first one here? It says administer lactated ringers 2 liters IV bolus over 1 hour. Now, before we go ahead and answer this one, I really want to emphasize here that when you approach this item, I want you to remember that our patient in this case is showing signs of hypovolemic shock in the setting of acute pancreatitis. So the first thing you need to do is to identify the interventions that will help stabilize perfusion, interventions that will correct dangerous electrolyte imbalances and avoid worsening the situation. Next is to carefully assess the lab values and the urine output, the vital signs. And using the clinical judgment measurement model, I want you to recognize those important cues, such as the severe hypotension, the tachycardia, the poor urine output, hypokalemia, hypomagnesemia, and make sure that those interventions that you will be selecting here will support circulation, correct those electrolyte imbalances, and prevent complications. All right, what do you think about the first intervention here? Do you think that is appropriate or inappropriate? Again, let me reread that. That's administer lactated ringer solution 2 liters IV bolus over 1 hour. The answer to this is appropriate. You should administer this fluid bolus right now because the patient has severe hypotension. That's 64/42. And going back into the lab data, the lactate level is really high. Of course, the patient has thready pulse. These are classic signs of hypovolemic shock. Now, the lactated ringers is appropriate in this case because it expands the intravascular volume quickly and it contains electrolytes that support perfusion, even though it's not really going to completely replenish the low potassium or magnesium, but there are some electrolytes and fluids in there. And so the intervention here can directly address the circulatory collapse and it will prevent multi-organ failure. Moving into the next intervention, it says administer furosemide 20 milligrams IV. The answer is inappropriate. You should not give the furosemide this time. This is a loop diuretic, which is a powerful diuretic drug. The patient in this case is already volume depleted. I should say severely volume depleted. And taking note about the urine output, he only had about 5 mL per hour. Now, if you're going to give this loop diuretic, this can worsen the hypovolemia. It will reduce the renal perfusion further. It will also increase the risk for acute kidney injury. Again, diuretics are contraindicated in the presence of shock and oliguria. I wanted you to remember the effects of any type of diuretic. It can cause hypotension. Our patient is already hypotensive, severely dehydrated. We don't want to remove more fluids from their system. Now let's get into the next intervention. It says administer potassium chloride 40 milliequivalents IV in 500 mL of 0.9 sodium chloride over 4 hours. What do you think about this? This is appropriate. You must administer potassium immediately as ordered. Now, I want you to pay attention to the patient's lab value, specifically the potassium, which was 2.4 when he came in. Now, with the infusion rate, I want you to recall that for a potassium replacement via IV, make sure that it does not exceed more than 10 milliequivalents per hour, especially because if your patient will receive more than that, let's say more than 10, let's say 20, if the patient is only having a peripheral IV access, and that's not recommended. So when a patient only has a regular peripheral IV access, then the limitation here is to only administer it within that infusion rate, 10 milliequivalents per hour. In the critical care, patients who have central line can possibly receive the potassium chloride at 20 milliequivalents per hour, provided that they are monitored continuously through the telemetry. Okay, so I want you to remember that the infusion rate and the consideration if they only have a peripheral IV access versus a central line. Now, this is also a life-threatening value for the potassium of 2.4. This can lead to cardiac arrhythmias, even cardiac arrest. Again, the rate here is within the safety guideline for peripheral administration. And per the order, there was something about rechecking the potassium level in 6 hours. So this will help ensure that we are tracking if the patient's potassium level is improving or not. And this is a priority electrolyte intervention that will support cardiac and neuromuscular function. Let's move on to our next intervention. It says administer insulin 5 units IV. The answer here is inappropriate. Around this time, you should hold off for the insulin administration, even though the glucose is elevated. I want you to remember the mode of action for insulin. Remember that it can cause increased uptake of the potassium from the vascular compartment. It will cause the shifting of those serum potassium into the intracellular space. So this can worsen the patient's hypokalemia. And another reason why this is inappropriate, it's because the provider has not ordered insulin in this scenario. And the patient's critical issues, we have shock, we have electrolyte imbalances. These two take precedence over managing the glucose level that's not really critical at this point. All right. So I want you to make sure that you are addressing first the perfusion issue, circulation issue, and the stability in the electrolyte levels first before we focus on the blood sugar control. Unless the glucose is dangerously high, or if the patient may have something of a hyperglycemic, hyperosmolar, non-ketotic coma, or if the patient had type 1 diabetes developing DKA. But at this point, this patient does not have those manifestations. And so insulin around this time, 5 units, is not appropriate. Moving on to the next one, it says administer magnesium sulfate 2 grams over 1 hour. The answer to this is appropriate. You should go ahead and administer the magnesium because the patient's level is 1.4 milligrams per deciliter, which is below normal. And I want you to remember that magnesium is critical for stabilizing cardiac rhythms. And if there is a deficiency, in a case of hypomagnesemia, this can also worsen hypokalemia. This can lead to torsades de pointe. Okay? And when you give this dose over an hour, this is safe according to the guidelines, also aligning with the standard treatment protocols. And this patient should be monitored continuously via telemetry during the administration, which is important to catch any rhythm disturbances. The next intervention, it says initiate enteral feeding via nasogastric tube. What do you think about this? This is inappropriate. Why you should not do this? Well, currently the patient is NPO for a reason, right? And even though if it said initiate enteral feeding via nasogastric tube, even if you're keeping the patient NPO, but if you're giving the nutrition through the nasogastric tube, this can stimulate the pancreas, it can worsen the inflammation, and it also contradicts the provider's order and the standard goal of care of allowing the pancreas to rest during acute episodes. Around this time, we're going to keep the NPO status. We're not going to give any nutrition via nasogastric tube. The goal for that is to lessen the inflammatory process, particularly the pancreas. All right. And when we're going to give the feeding via nasogastric tube, this can also increase the risk of aspiration, especially in this unstable patient. Next intervention, it says position the patient in semi-Fowler's. This is appropriate because this can help respiratory effort and abdominal discomfort. I should say this can lessen the abdominal discomfort. And with the patient's respiratory rate of, I think that was about 28, and also distension from pancreatitis, when we are elevating the head of the bed, this will reduce the diaphragmatic pressure. And this is a very simple, it is a non-invasive intervention that can help improve the patient's ventilation. It will make him more comfortable. And again, it can also reduce the risk of aspiration. Next one we have is administer hydrocortisone 100 milligrams IV. This is inappropriate. We should not give steroids such as hydrocortisone this time unless there is a clear reason, such as adrenal insufficiency or septic shock, which has not been diagnosed in this case. And this drug is not part of the provider's orders. If you pay attention to the healthcare provider's orders, this can also cause the unnecessary complications, which will lead to worsening hyperglycemia. And if you are giving any corticosteroid without any valid indication, it's not only unsafe, but it may delay more appropriate care. And so this time we need to stick to interventions that are supported by assessment and provider orders. What else do we have? We have a monitor telemetry for QT prolongation. This is appropriate. We are going to continue the cardiac rhythm continuously and closely because the patient already has a corrected QT interval of 440 milliseconds. And take note that the patient has hypokalemia, hypomagnesemia, and both of these electrolyte imbalances will increase the risk for life-threatening arrhythmias. Now, I want you to pay attention onto that QT or corrected QT interval. What does that mean? So normally, a corrected QT interval should be normal. For men, it should be less than 440, and for women, it should be less than 460 milliseconds in females, right? So the C in the QTC, if you look back into the physician's orders and the documentation, the C stands for corrected for the heart rate, since the QT interval naturally shortens or lengthens depending on the heart rate. And I want you to recall that the QTC is actually a measure on the ECG that reflects how long it takes the ventricles to depolarize and repolarize. So this is basically measuring the contraction and the reset. Now, moving into the next intervention, we have administer platelet transfusion 1 unit. What do you think about this one? Platelet transfusion. You can go back into the lab data. If you can pause for a minute, if you want to review that, what do you think about this? The answer for this item is inappropriate. Even though the platelet count is around 100,000, the transfusion for platelet is not indicated unless the patient is actively bleeding. And if you are going to do that now, this can also expose the patient to unnecessary risks, including transfusion reactions. And also, there was no order from the healthcare provider about transfusing this patient. There is no clinical indication for this procedure. So eliminate this one. Eliminate in the sense that we're going to mark this intervention as inappropriate. So I hope that you're able to capture all those items in their correct spots. Moving into our next item, we have a multiple response grouping. And there's an update regarding the emergency department progress notes. It said at 6 a.m. This was entered at 6 a.m. But it said here, potassium chloride 40 milliequivalents IV started at 5 a.m. Magnesium sulfate 2 grams IV at 5. No tetany. Foley catheter patent. Closed system maintained. Oral care provided. Enoxaparin 40 milligrams subcutaneously at 5. Patient complained of epigastric pain at 8 out of 10 numerical pain rating scale. Nausea persists. Abdomen is distended, tender, hypoactive. Bowel sounds. Blood pressure 88/56. Heart rate 124. Respirations 24. Saturation 95% on 2 liters per minute. Nasal cannula and temperature of 100.7 degrees Fahrenheit. Telemetry showing sinus tachycardia. Corrected QT interval of 445 milliseconds. Hydromorphone 1 milligram IV at 5:30. Pain now 6 out of 10. Ondansetron 4 milligrams IV at 5:45. No vomiting. Urine output 10 mL per hour via Foley dark amber. Lactated ringers bolus completed. Maintenance at 300 mL per hour. Few petechiae noted on thighs. Wife anxious. Asking about their recovery timeline. Let's move on to our next medical record information. We have some lab results with the amylase at 360, lipase 190, lactate 4.0, glucose 240, creatinine 1.3, potassium 2.4, calcium 7.8, magnesium 1.4, 17,000 for the white blood cells, and platelet 100,000, LDH 400, and 300 AST. And we also have the healthcare provider order. There's an update to do chest x-ray to rule out pleural effusion. And this was ordered at 6 in the morning. Now, in this item, I want you to pay attention here because the patient is somewhat or just slightly more stable. So you are now shifting your focus to managing the lingering symptoms like pain, nausea, and preparing for a CAT scan. Now, as a nurse, taking the role of the RN in this case, you must make sure the patient is safe, comfortable, and ready for imaging without duplicating the interventions or giving anything that's not ordered. And I want you to pay attention to what has already been done, like medications just given, and what still needs to happen. Could be maybe placement of IV or maybe monitoring of urine output. So I want you to use this opportunity to apply those nursing priorities to a more recovery-focused phase of care. So here's the rest of our test item. We got an instruction to select 2 interventions for each category to manage symptoms and prepare for diagnostics. And this is our table for the matrix. There are 3 categories: symptom management, diagnostic prep, and monitoring. Now let's go into the correct options first for each category. Now, what do you think about the options here? What do you think are the correct answers? If you selected the positioning in semi-Fowler's with knees flex, this is one of the correct answers, because this is going to reduce the abdominal pressure and it will improve breathing, especially since the respiratory rate is already increased. And the flexing of the knees can also ease the strain on the abdominal muscles. This will help reduce the pain. Again, very practical. It's independent, nurse-driven strategy that will support comfort and respiratory function. What else do we need to do here? We are going to provide oral care for NPO status. Even though the patient has an order for nothing by mouth, you can still provide comfort by performing regular oral hygiene. This can be impactful to the patient. It will prevent mucosal dryness. It will reduce infection risk, especially important when there was a prior frequent vomiting and the patient was also dehydrated. If they're not allowed to take anything by mouth, they're not able to sip water, the mucous membranes there can be so dry and they can start to crack. So this is a very basic nursing action that you can do, but it's very critical that it can promote dignity and care. Now, what are the incorrect options here in this category? Of course, we have administer ondansetron 4 milligrams IV PRN. Even though the medication was ordered PRN or as needed, I want you to pay close attention that the medication was specifically ordered to have an interval of every 6 hours. And in the case scenario, the nurse already administered a dose less than an hour ago. And so if you're going to give another dose before the 6-hour interval, this risks overdose and also is putting the patient for potential QT prolongation. Remember that the patient's corrected QT has already elevated. So you need to adhere to the medication timing, which is very crucial for the patient safety. Now, another thing that you are supposed to not do here is to encourage deep breathing. This is inappropriate. We know that this procedure can help prevent atelectasis, but the patient is still in acute distress with pain and nausea. So the first thing that you should do is to control these symptoms before you encourage respiratory exercises. So timing and prioritization are key here. All right. Your patient will not have satisfactory relief from just doing the deep breathing exercise without proper control of their pain. Now let's go into the other option. It says administer 5 units of insulin IV. Again, we know that the glucose level was elevated, but it's not dangerously so. And so you do not have an order to give insulin this time. And we have much more pressing issues such as the electrolyte abnormalities and shock. Again, I want you to remember that insulin can cause more hypokalemia. You're not supposed to inject more of, or you're not supposed to give insulin because, again, it will worsen the hypokalemia. Let's move on to the diagnostic prep category. What do you think are the correct answers here? One of the answers is to ensure IV patency for CT contrast. We want to make sure that there is good blood return before we use the IV axis, especially if we are about to send the patient to the radiology department. And if we are not going to do this, if there's failure in checking the patency, this can delay any infusion that was supposed to be given already. It's also going to delay the CAT scan procedure. It possibly can lead to canceling because of no patent IV access. So this is very routine, but it has very critical benefits for the scenario. Now, whatever we have here, another option that you should select is to verify NPO status. Again, we have an order to keep the patient NPO. This is to prevent aspiration during the CAT scan, and it can also ensure accurate diagnostic without interfering from any presence of any food items or liquids. And so you can reinforce this with the patient and family, make sure that they know that patient is supposed to be NPO so that they will have that correct understanding to maintain safety. And again, very important, especially that we need to comply with contrast protocols. Now, what about administering diphenhydramine 25 milligrams IV for a contrast allergy? Do you think that this is appropriate? This is not ordered according to the set of orders that we just reviewed. And this is not given prophylactically unless the patient has a known contrast allergy. You have to verify allergies before administering medication, and giving this without any valid indication can also mask early signs of a true reaction. It can also cause undue sedation to this patient. Now, if you selected obtain an order for repeat lipase level, now this is not really needed around this time because the lipase has already been assessed and it's not an immediate priority. Again, this is an unnecessary duplication of care. And if you selected position patient supine for CT, well, you do not need to pre-position the patient for the CAT scan. This is the responsibility of the CAT scan technician. Your role before transporting the patient is to prepare the patient clinically, but not physically move them into the scan position. And if you did this one, it could cause discomfort or maybe interfere with the procedure. So be careful. Now, let's move into the monitoring category. What do you think about the answers here? Well, the first answer for this category is to monitor urine output every 1 hour via Foley catheter. And I want you to pay attention that the urine output is still low at 10 mL per hour. So this is something that you need to monitor hourly to assess renal perfusion and function. And detecting the worsening of the perfusion or the acute kidney injury is very critical here. And documentation and trending are very important for the provider for reference in order that they can decide of what to do next. Now, what else do we have to check off here? The other one is to maintain Foley catheter with closed drainage system. This is very important to reduce the risk of catheter-associated infections or CAUTI. And this also helps ensure that we are accurately measuring the urine output. And if there's any break in the system, this can also compromise the sterility and integrity of our closed system. So make sure that we're not pulling any parts of the tube apart. Now, what else do we have as that we need to consider as incorrect options? So one of those is assess pain every 2 hours using the numerical pain rating scale. Why do you think that we are not checking off this one? We know that pain assessment is very important, but we just administered the pain medication and we just reassessed the pain score just recently. Now, reassessing the pain every 2 hours without any clear indication, this can become very excessive and it can be tiring for the patient. And so what you should focus is to remain on the current interventions and the patient's response. Now, if you selected monitor blood glucose every 4 hours, this is inappropriate because we don't have an order to do so. And the patient's current glucose level is not dangerously elevated. So your priority is to focus on the fluid resuscitation and the correction of the electrolytes. Moving into our next option that you should not check off here is check for petechiae expansion. This is inappropriate this time. Again, this time. Because the petechiae were already noted. And while you should keep an eye on them, this is not a high priority action at this moment. Remember that the instruction said, select 2 interventions for each category to manage symptoms and prepare for diagnostics. There are more pressing concerns, such as fluid status and diagnostic preparation. So this one is something that you can address during routine skin assessment. So I don't want you to stray away from what's necessary around this time. Okay? I hope that you got all those correct answers. Let's move on into our next item.
Before we move ahead, here's something you shouldn't miss. If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's continue with the topic.
So here we have a test matrix, multiple choice or multiple response. You will see it in a minute. Now, pay attention to the lab results one more time. There's an update right now. These are lab results for the blood drawn at 5:30 in the morning. So our amylase is 200, lipase 100, lactate 2.9 from 4.0, calcium of 5.6, magnesium 1.6, potassium 3.6, glucose 190, white blood cell count 18,000, platelet count 60,000, creatinine 1.8, BUN 30, and the heparin-induced thrombocytopenia antibody is positive. We also have a result for the chest x-ray done at 5 in the morning. It showed bibacillar atelectasis, no acute respiratory distress syndrome or adult respiratory distress syndrome. And the abdominal exam showed some tenderness, distension, and hypoactive bowel sounds. Let's move into the next section of the medical record. We have some ICU provider orders. Take note here, we are on day 2. All right, we are on day 2. The patient has been transferred to intensive care unit, and these orders were entered at 6 in the morning. So we have the orders: lactated ringers, IV at 250 mL per hour, titrate to urinary output greater than 30 mL per hour, insulin drip, target glucose 140 to 180 milligrams per deciliter, calcium gluconate 1 gram IV every 6 hours until calcium is greater than 6.5 milligrams per deciliter, incentive spirometry every 2 hours, consult pulmonary for ARDS risk and BiPAP evaluation, argatroban for hematology for the heparin-induced thrombocytopenia management. It said initiate argatroban if confirmed. We also have an order to monitor for the SIRS or SIRS. This is that systemic inflammatory response, right? And we have an order for repeat chest x-ray if oxygen saturation is less than 90%. Hold enoxaparin, monitor platelets every 12 hours, maintain Foley catheter to monitor urine output, ensure closed drainage system, and stat heparin-induced thrombocytopenia antibody test, and repeat comprehensive metabolic panel to monitor creatinine and BUN. All right, we have more records to review. We have the intensive care unit progress notes this time. This is on day 2. At 5:55 in the morning, notified healthcare provider for the lab results. At 6 in the morning, received new orders. Patient complained of epigastric pain, 7 out of 10 per numeric pain rating scale. No nausea, vomiting, tender abdomen, distended, hypoactive bowel sounds, blood pressure 96/62, heart rate of 110, respirations 26, saturation 92 on 4 liters per cannula, temperature of 101.2 degrees Fahrenheit. Telemetry showed sinus rhythm, corrected QT interval of 460 milliseconds. No ectopy. Urine output 15 mL per hour via Foley, dark amber. Bibacillar crackles noted. Oral care provided. Petechiae on thighs increased. Patient anxious. Wife at bedside. All right, you can pause this video at this time if you want to go back into those important details. And right now, we'll proceed. You can, again, pause the video momentarily. Now, how are you going to answer this question? We have the instruction here. It says, select all applicable descriptors, do now, do not do, and one expected outcome per intervention. At least one option per column. So we have the table right here. Now, how are you going to answer this? Remember that your patient is already in the ICU with worsening complications of the pancreatitis. Your patient now has hypocalcemia that is more severe. Atelectasis, there's a possibility that there's heparin-induced thrombocytopenia, or what we call as HIT. There's also signs of early acute kidney injury. So around this time, you got to prioritize the actions that are most urgent to prevent further deterioration. And you have to look closely at trends in the laboratory results and vital signs, especially the low calcium, the low platelets, elevated creatinine, and worsening respiratory status. So here, your goal is to identify the right interventions and predict the outcomes that you suspected from those actions. Now, let's get into our first intervention. It says, administer calcium gluconate 1 gram IV. The answer is do now. You gotta administer it right away because the patient's serum calcium is critically low at 5.6 milligrams per deciliter. And the hypocalcemia around this level can cause muscle cramping. There's going to be tetany. There's going to be seizures, cardiac dysrhythmias, especially a prolongation of the QT interval, right? Remember that the QTC was already 460 milliseconds. So when you give the calcium gluconate here, this will help stabilize neuromuscular and cardiac function. And this also aligns with the provider's order, which is life-saving. All right. So the expected outcome here should be an increase above 6.5 milligrams per deciliter. So it will reduce the risk of tetany and arrhythmias. So I did not include the expected outcome in the table, but at least this will help guide you to what really matters here. All right. Now, what about the second intervention? It says monitor telemetry for QT prolongation. What do you think about this one? This is do now. You have to continue monitoring the patient's cardiac rhythm because of the prolongation. Remember about the 460 QTC, and the hypokalemia, the hypomagnesemia are known to worsen this. And this monitoring can allow you to detect the torsades de pointe and the ventricular tachycardia early. And also, you make sure that you are checking on this, especially if you have this patient that has some significant electrolyte imbalances. This is a standard high priority nursing action in intensive care unit. All right. Now, what about encourage incentive spirometry every 2 hours? What do you think about this? This is also a do now. You need to reinforce the use of the IS because the patient has bibacillar crackles and documented atelectasis on the imaging. And I want you to pay attention about the hypoventilation from the pain. Immobility also increases the risk of respiratory complications such as pneumonia and adult respiratory distress syndrome. So when you are encouraging deep breathing, this will help reopen the patient's alveoli. It can help improve the oxygenation, even though the patient is fatigued, but you can help them pace through the use of the IS and also help them motivate their use every 2 hours. Alrighty. Now moving into our next intervention, prepare for BiPAP initiation per pulmonary consult. What do you think about this one? This is also requiring do now. You should anticipate and prepare for the BiPAP as recommended by the pulmonary consult because the patient's respiration is already elevated at 26 cycles per minute and their oxygen saturation is I should say borderline at 92 on 4 liters, and their lung exam revealed crackles. All these signs point to worsening respiratory status. And when we have the BiPAP, this can help reduce the patient's work of breathing. It will improve their ventilation. And if we have the equipment ready, we want to make sure that the patient is educated about the reasons and the benefits in order for us to gain cooperation from the patient, right? Before the patient's respiratory fatigue sets in. Now, another intervention is administer lactated ringers 500 mLs IV bolus over 30 minutes. What do you think about this? This is do not do. We're not going to administer a fluid bolus at this point because it's not ordered and the patient is showing early fluid overload signs. There's also impaired oxygenation. There's presence of crackles. And the saturation of 92 on 4 liters per minute via nasal cannula and the respiratory rate of 26 are not really good signs. Although a small amount of bolus might be considered in hypotensive patients without any pulmonary compromise, but the patient that we have in this case, especially their lungs are already affected, and if we're going to add rapid infusion, this can worsen their pulmonary edema. And in addition to that, we have the urine output here that is low. The creatinine is elevated. It suggests early acute kidney injury, which also further limits the kidney's ability to handle fluid shifts. So what you should do here is to administer a controlled maintenance rate as ordered by the healthcare provider, and also to reassess the clinical volume status of our patient and make sure that we are doing this promptly to prevent more complication. All right. I want you to go into the next intervention here. It says switch enoxaparin to argatroban per hematology consult. Is it do now or is it do not do? What do you think about that? All right, just correcting the table. All right, moving on. We have switch enoxaparin to argatroban per hematology consult. What do you think about that intervention? You think that this is a do now or do not do? This is a do now. Just click on that one. You have to follow up on this consultation and ensure that there is transition to the argatroban, which should be implemented. Now, I want you to recall what argatroban is. This is an anticoagulant, which is a thrombin inhibitor, which is used as an alternative to the enoxaparin that the patient previously received in our first two cases, or our first two test items. Again, our patient had the HIT, or the heparin-induced thrombocytopenia. And I want you to pay attention to the lab value that the patient's antibody is positive to HIT. And there is already considerable drop in the platelet counts to 60,000. And this indicates HIT. And when you do this now, such as switching enoxaparin to argatroban, this is time sensitive and also very critical for patient safety. So the outcome on this one should help stabilize the platelet count and also decreasing the risk of thrombosis, especially that our patient has that HIT development. Now, moving into our next intervention, it says initiate platelet transfusion 1 unit. Is it do now or do not do? The answer is do not do, because there is no order for platelet transfusion. And I want you to pay attention right now. Platelet transfusion is not indicated at 60,000 because it exceeds the American Association of Blood Banks threshold, usually around 10,000 for prophylactic transfusion in stable, non-bleeding patients. So I want you to pay attention to this guideline. Now, in heparin-induced thrombocytopenia, transfusion of platelets is also avoided unless there is life-threatening bleeding that can happen. And this is according to the American College of Chest Physicians guidelines due to thrombosis risks. And so only minor petechiae are present in this situation, and the argatroban will help address the heparin-induced thrombocytopenia. So what you should do here instead is to monitor the patient closely for the signs of significant bleeding, maybe mucosal oozing or maybe hematuria, and make sure that you follow up on the hematology's recommendations to start the argatroban, which will help protect the patient from clot formation, and it will also allow platelet levels to gradually recover. Now, moving into our last option, we have administer hydrocortisone 100 milligrams IV. This is a do not do because there's no current provider order or there is no indication for administering this drug. There is no adrenal insufficiency. There's no septic shock. So none of those are supporting for this medication. And in this case, with an acute pancreatitis, especially that the patient has HIT, when you give the corticosteroids without indication, this can cause complications. It can worsen the patient's elevated blood sugar, right? So the more that the patient will experience hyperglycemia, it can also increase their risk of infection. And take note that their white blood cell count is already 18,000. And it can also cause fluid retention, which could strain the already impaired kidneys. Remember that their creatinine level is already skyrocketing. So you should prioritize the treatments that are already ordered, such as the calcium gluconate, the argatroban, which are all aligned with the evidence-based care for this patient with acute pancreatitis. All right, so I hope that you were able to capture all the options here and the correct interventions. Let's have our fourth item. So here we have our patient still on day 2, and time stamp is at 5:30. It looks like our patient's lab values are quite the same. And the chest x-ray showed bibacillar atelectasis, no ARDS, abdominal exam, tender, distended, hypoactive bowel sounds. Now, the instruction is to select the appropriate action and rationale for the patient's most recent assessment findings. So, quickly glance into the diagnostic test and the lab data. Let's proceed to the next page, which is all about the healthcare provider orders in ICU day 2. So I want you to scan all these. It said lactated Ringer's IV at 250 mL per hour, titrate to urine output greater than 30 mL per hour. Insulin drip, target glucose 140 to 180 milligrams per deciliter. Calcium gluconate, 1 gram IV every 6 hours until calcium is greater than 6.5 milligrams per deciliter. Incentive spirometer every 2 hours. Consult pulmonary for ARDS risk and BiPAP evaluation. Argatroban per hematology for HIT management. Initiate argatroban if confirmed. Monitor for SIRS. Repeat chest x-ray if saturation is less than 90%. Hold enoxaparin. Monitor platelets every 12 hours. Maintain Foley catheter to monitor urine output. Ensure closed drainage system. Stat HIT antibody test. Repeat comprehensive metabolic panel to monitor creatinine and BUN. Now, the instruction for you is to, well, before we go to do that, there's new documentation for the nurse's notes. It said, at 5:55 in the morning, notified healthcare provider for lab results. At 6, received new orders. Patient complained of epigastric pain, 7 out of 10. No nausea, vomiting, no tender abdomen, distended hypoactive bowel sounds, blood pressure 96/62, heart rate 110, respirations 26, oxygen saturation 92 on 4 liters, temperature of 101.2 degrees Fahrenheit. Telemetry showed sinus rhythm. We have corrected QT interval 460 millisecond, no ectopy, urinary output of 15 mL per hour via Foley, dark amber. Bibacillar crackles noted, oral care provided, petechiae on the thighs increased, patient anxious, wife at bedside. Here's the update. At 6:15, argatroban initiated per hematology. Patient is fatigued, wife is concerned. 6:45, blood pressure is 88/52, heart rate 120, respirations 24 per minute, saturation of 94 on 4 liters per minute, nasal cannula, glucose level 180 milligrams per deciliter, and at 7:30, urine output 20 mL via Foley, dark amber. All right, you can review this on your own, and if you need to take some time to review, you can pause this video. Now, how are you going to answer this question? At this point, the patient is showing signs of poor perfusion. There is hypotension, low urine output, there is elevated lactate, all pointing toward hypovolemic shock. Now, your job here as the nurse is to figure out which intervention best supports tissue perfusion and which could align with what was ordered by the doctor. So I want you to stay focused on what improves circulation without worsening the kidney injury or deviating from the plan of care. Now let's take a look into the table here. So we got a spot for the action and the rationale why we are doing that action. And here are the following options for the action. It said administer oxygen via a non-rebreather mask, administer 5% albumin 500 mL IV, increase insulin drip to 3 units per hour, titrate lactated ringers to urine output greater than 30 mL per hour. Now for the rationale, we have the options to improve oxygenation, to enhance oncotic pressure, to achieve tighter glucose control, and lastly, to restore intravascular volume and tissue perfusion. Now, what would be the correct answer here? The answer is to titrate lactated ringers to urinary output greater than 30 mL per hour. And the rationale for this is to restore intravascular volume and tissue perfusion. This is the right move because the patient is still showing signs of hypotension and poor kidney perfusion. Their urine output is very low and their creatinine is also increasing. These are classic signs of early acute kidney injury. Now, if you're adjusting the fluid rate to meet the urine output goal, this is going to help restore the volume without overloading the patient's system. And this is also backed by clinical guidelines and also fits your role in improving the tissue perfusion during hypotensive shock, right? Or hypovolemic shock, I should say. So the rest of the options here, such as increase insulin drip to 3 liters or 3 units rather per hour, that is incorrect. Even though we are already administering the insulin, the glucose is already within the target range. Remember about the target range that the order said? It is within that limit. And so there's no need to push the glucose much lower because we want a much tighter control, and this could eventually cause hypoglycemia if we are too stringent with that. So the main focus here is not about the blood sugar, but we need to stabilize the circulation and the kidney function. And take note that we still have some electrolytes that needs some more of stabilization, I believe. And if you're going to administer the albumin here, it's at 5%, 500 mL IV. This is incorrect. Even if this one sounds helpful, but it is not recommended for fluid resuscitation in pancreatitis. What is intended or recommended here is the lactated ringers. It's much more effective, it's safer for patients with possible kidney issues, and the albumin is not supported by strong indication in this setting, and this could actually cause more harm than good if there is fluid accumulation, especially. Now, what about administer oxygen via non-rebreather mask? This is also not indicated because our patient's oxygen level is fine on 4 liters, 92 right now. Okay, this is something that can be improved with some deep breathing, but putting them on a non-rebreather mask, it could actually hide signs of real respiratory decline, and it can possibly cause oxygen toxicity, right? And it is very important for us to match the oxygen delivery method to the patient's actual need, not just assume more is better. So I want you to keep that in mind, right? Non-rebreather mask is so aggressive for this kind of scenario. So I hope that you're able to capture all those correct answers here. Let's move forward to our next item, which is a highlight or the hotspot type of test. So the instructions stated, highlight the findings indicating a need for immediate nursing intervention to address life-threatening or rapidly deteriorating conditions. So these documentations are actually reflective of what we read earlier in the progress notes. So this is still on day 2, ICU. So let's just scan through here. At 5:55 in the morning, notified healthcare provider for lab results. 6 a.m. received new orders. Patient complained of epigastric pain, 7 out of 10. Per numeric pain rating scale, no nausea, vomiting, tender abdomen, distended, hypoactive bowel sounds. Blood pressure 96/62. Heart rate 110. Respirations 26. Oxygen saturation of 92 on 4 liters per nasal cannula. Temperature of 101.2 degrees Fahrenheit. Telemetry, sinus rhythm. Corrected QT interval 460 milliseconds. No ectopy. Urine output 15 mL per hour. Via Foley, dark amber. Bibacillar crackles noted. Oral care provided. Petechiae on the thighs increased. Patient anxious. Wife at bedside. 6:15. Argatroban initiated per hematology. Patient is fatigued. Wife is concerned. 6:45. Blood pressure 88/52. Heart rate 120. Respirations 24 per minute. Saturation 94 on 4 liters per minute nasal cannula. Glucose level 180. Urine output 20 mL via Foley, dark amber. Now, how do you answer this test question? In order for you to successfully highlight those correct options or phrases and words is for you to sift through all the details and zero in on the what's concerning right now. And in this documentation, some of the findings are expected already in pancreatitis, but the others point to life-threatening problems. And I'm not going to say those clues right now. So what you need to highlight here are those items that demands action. Something that you'd prioritize during your shift handoff or before calling the medical provider. So again, all those findings that are associated with life-threatening conditions or could be rapidly deteriorating assessment findings, right? So what are these phrases that you should highlight? One of those is the vital signs of blood pressure, heart rate, respiration, saturation, and temperature. This is such a cluster, all right? We're not actually highlighting them individually. This is a cluster for this patient at 6 in the morning. So this set of vital signs are abnormal, all reflecting that there is a problem. There is instability in their hemodynamics. There's hypotension, tachycardia, respiratory distress. With a tachypnea, there is hypoxemia. There is also potential infection or inflammation as evidenced by the fever, right? So all of these indicate life-threatening condition such as hypovolemic shock, could be the SIRS, or could be early sepsis, and these reflect a necessity for us to intervene right away. Could be administering fluid resuscitation, could be titrating the oxygen, and also possible sepsis workup, right? So pay attention here. These are pointing towards life-threatening issues: shock, respiratory failure. So that's why these are, this is a cluster. Now, what else do we need to highlight here? The next one is urine output of 15 mL per hour via Foley, dark amber. This is oliguria. The dark amber color of the urine suggests that there is acute kidney injury from severe hypovolemia. Both are life-threatening complications of acute pancreatitis. We need to intervene right away. We need to administer fluids, making sure that we are monitoring into the renal function, and also to monitor the hourly output. Again, this meets the criteria of acute kidney injury. Again, this is a life-threatening condition, which is rapidly deteriorating. Next is bibacillar crackles noted. these crackles indicate that there is pulmonary edema, or it could be adult respiratory distress syndrome. Both are serious complications of severe pancreatitis. Also life-threatening. We should intervene on this one, possibly increasing the oxygen therapy, possibly keeping an eye onto the fluid infusion that we are administering, and also make sure that we are monitoring the integrity of our pulmonary function in our patient through the use of chest x-ray, if there is a need for us to follow up on that one as well. Now, what else? We have petechiae on the thighs increased. These petechiae suggest that there is DIC, or disseminated intravascular coagulation, which is also a life-threatening complication of pancreatitis. We need to promptly evaluate this patient with coagulation studies, a platelet count, and also to intervene to prevent further systemic complications. Now, what else do we have in our case? We have the vital signs: blood pressure 88/52, 120 on the heart rate, respirations of 24, saturation of 94 on 4 liters. And this are assessment findings at 6:45, right? And these are indicating worsening hypotension and tachycardia. This is now progressive hypovolemic shock and possibly sepsis. And the tachypnea also indicates that there is respiratory distress. Again, these are life-threatening manifestations that we need to intervene right away. This patient might need some vasopressors, maybe more fluids, or maybe escalation of care. Now, what else do we need to highlight here? There is that urine output of 20 mL via Foley dark ember at 7:30 in the morning. Again, our patient is having persistent oliguria. Again, the patient still has continued acute kidney injury or hypovolemia. This is also concerning because the patient has not responded to the initial interventions that we just did. This is also life-threatening. This also requires escalation and making sure that we are making follow-up onto our consultation with nephrology as ordered. Now, what are the items that we should not highlight here? Well, one of those is the epigastric pain of 7 out of 10 per numeric pain rating scale. And that is something that was assessed at 6 in the morning. Why are we not highlighting this one? Again, this is an expected symptom in acute pancreatitis. This is significant, but it's not immediately life-threatening. Of course, there's absence of nausea or vomiting, which reassures and also further reduces the urgency of the pain level. We still need to address the pain level, but it's not life-threatening, okay? It doesn't require as urgent intervention as we are going to do for the other issues that we had identified. Now, the other one is tender abdomen, distended, hypoactive bowel sounds. These are also consistent with the pancreatitis because of the inflammation. There's also ileus that is expected. Of course, there are no signs suggesting acute complications like necrosis or perforation, so the findings do not require immediate intervention right now. What else? We need to cross off into the telemetry sinus rhythm, QTC 460 millisecond, no ectopy. This is not really life-threatening. We need to keep monitoring this one, all right? There is no immediate arrhythmia right now, and the cardiac complications are less urgent compared to the hemodynamic and the organ dysfunctions that we already identified. What else? If you selected or if you highlighted about the patient that was anxious, wife at bedside, this is a psychological finding. It is not a life-threatening issue, even though it reflects discomfort or distress, but it does not require immediate psychological and physiological intervention. I did not say that we're not going to address this, but again, we need to address the physiological needs that are more pressing this time. What else? Patient is fatigued. Where is that? Patient is fatigued, wife is concerned. And take note that fatigue is non-specific. It's not life-threatening. It may be part of the overall illness, but it does not necessitate immediate action right now. And the family concern is psychosocial, which does not take precedence over the physiological needs. That's why we are not going to highlight that one as well. Now, the glucose level of 180 milligrams per deciliter is something that you should not highlight right now. We know that this is concerning, but not life-threatening. Okay? Our patient is already receiving the insulin infusion. So this hyperglycemia right now reflects the stress response and, of course, the acute pancreatitis. It requires monitoring, but it is less urgent compared to the other issues that we had identified as life-threatening. And I hope that you were able to capture all the correct ones and eliminate those distractors. Let's move on into our next. Alrighty, let's proceed to our next test item.
Before moving ahead, here's something you need to hear if you're feeling anxious about passing the NCLEX, especially if you're aiming to do it in 1 week or 1 month. Then our complete online NCLEX review crash course is your answer. This is your shortcut to success, a tried and tested course with a 99% passing rate. More than 5,000 students have achieved their NCLEX goals using this course, and now it's your turn. Here's what's included. 100-hour animated mini crash course, perfect for last-minute preparation to pass in just 1 week. 300-hour comprehensive lectures covering 300 high-yield topics that the NCLEX loves to test. 5,000 real NCLEX questions. Train with real exam-style questions and be prepared for anything. 15 full-length practice tests, including CAT simulation. Build your confidence with realistic exam experiences. Exclusive NCLEX ebook and 1-year access. Study whenever you need without restrictions. Don't let this opportunity slip away. Enroll now at 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's jump into the topic.
Number 6. This is a bow tie test type. And we have progress notes. It said at 7 in the morning, this is day 7, and the step-down unit. It said, patient in step-down unit alert, complain of mild abdominal discomfort, 2 out of 10 per numeric pain rating scale. No nausea, vomiting, vital signs, blood pressure 122/78, and heart rate of 84 beats per minute, respirations 18 per minute, saturation 97% on room air, temperature of 98.6 degrees Fahrenheit, telemetry, normal sinus rhythm, the corrected QT interval of 430 millisecond, urine output of 50 mL via Foley, clear yellow, abdomen soft, non-tender, bowel sounds active, fall rest precautions implemented, bed alarm, non-skid socks, call light within reach, and alcohol cessation counseling is scheduled. Patient reports occasional dizziness when standing, denies epistaxis or melena. Wife is concerned about dietary compliance. There's petechiae on forearms, thighs, scattered ecchymosis on flanks, no Cullen sign or Gray Turner sign, no mucosal bleeding, orthostatic blood pressure of 118/74, sitting 110/70, standing, heart rate of 88, standing. Foley, patent, closed system, maintain. Now, I want you to pay attention to the clinical scenario and follow the instructions carefully. And we have the following options for the options. But before we go do that, we have the step-down healthcare provider orders. It said clear liquid diet, advance to low-fat diet as tolerated, metformin 500 milligrams twice a day, hydromorphone 0.5 milligrams IV every 6 hours is needed for pain greater than 3 out of 10, alcohol cessation counseling, discharge planning, stat hematology consult for thrombocytopenia, repeat lipase and triglycerides if pain worsens, orthostatic blood pressure or vital signs every 4 hours, platelet count every 12 hours, avoid invasive procedures, maintain Foley catheter to monitor urine output, ensure closed drainage system. Here we go. We have the diagnostic test results that show that the chest x-ray, patient's lung sounds are clear. There's resolution of atelectasis, and the abdominal CT said something about pancreatic necrosis resolved, small peripancreatic fluid collection, 2 centimeter, no pseudocyst. All right. Here are the following options for our bow tie. For the complication, it said about hypertriglyceridemia-induced pancreatitis, exacerbation, postural hypotension, thrombocytopenia-induced bleeding, pancreatic pseudocyst formation, and recurrent pancreatitis. Now, what do you think would be the correct answer here? So, when you address this patient, you have to pay attention that you are now taking care of a recovering patient from the pancreatitis, right? Now, at this point, their platelet count is actually low, and there's more manifestations that you have seen. So your focus is to shift to preventing bleeding complications. And I want you to review the clinical findings, identify the most urgent problem, and you have to choose the safest and most effective interventions and make sure that you monitor for the early signs of deterioration. There's no other answer to this potential complication around this time. The most appropriate here is thrombocytopenia-induced bleeding. And the platelet count that was already low, the petechiae, there's a bruising, which indicate bleeding risk. Even if the patient has not started bleeding actively, no gum bleeding or no hematuria or even no bleeding in the rectum, you need to intervene right now to reduce the chances of internal or mucosal hemorrhage. So this is the most pressing issue and also takes priority over the other long-term concerns that we have seen here. If you selected recurrent pancreatitis, well, the patient's lipase is within the normal limits. The pain is also mild. And at this point, you do not have any evidence of an active pancreatic flare. So this doesn't require immediate attention. And the focus that you should be on to will be the bleeding risk, not about the digestive enzymes. If you selected the pancreatic pseudocyst formation, this is also incorrect because the imaging that we just read also ruled this out, and it showed small peripancreatic fluid collection that was noted. It's stable, it's non-urgent. So this is something that we can monitor, but not act on it as the primary concern. We have postural hypotension. We know that the patient complained about dizziness when standing, and the orthostatic vitals are mostly stable, not dangerously low. So you already have fall precautions in place. And this is something to continue monitoring, but it's not the complication that demands the most immediate action this time. If you selected hypertriglyceridemia-induced pancreatitis exacerbation, this is also incorrect. We know that the triglycerides are elevated, but not at a level that can cause acute pancreatitis. The patient's pancreatic enzymes are stable right now, and the symptoms are also resolving. And you can address this in follow-up education, not an urgent complication. Now let's move into our nursing actions. So there should be 2 here, and the options are educate on alcohol cessation and relapse prevention, implement fall risk precautions, teach patient to rise slowly from sitting to standing, instruct on low-fat, low-triglyceride diet adherence, initiate bleeding precautions, notify hematology for urgent evaluation. Now, the 2 actions that you should pick here are to initiate bleeding precautions. This is one of the safest and most effective things that you can do independently, especially that there is now decreasing platelet count, and the risk of spontaneous bleeding is very real this time. And make sure that your precautions should include using or allowing the patient to use a soft toothbrush, avoiding invasive procedures, and also preventing trauma, which are all critical right now. Another intervention that you should select is to notify hematology for urgent evaluation. And this has already been ordered, but you must ensure that it happens without delay. And with the platelet count that is already low, the input from the hematology or hematologist is very critical for them to determine if the patient needs possibly a transfusion or other treatment. And we need to follow up on this promptly to prevent more complications. Now, if you selected educate on alcohol cessation, this is incorrect. We know that this is something that can be applied for long-term recovery, but this time it won't reduce the immediate risk of bleeding. So you should follow the education of alcohol cessation once the patient is more stable. This is something that can wait until the patient is much more stabilized. If you selected implement fall risk precautions, this is always smart, but this has already been done and documented, and you don't need to take additional steps unless the patient worsens or if there are new symptoms emerging. This is not your top action today, and this action does not point to the thrombocytopenia induced bleeding. If you selected teach patient to rise slowly from sitting to standing, we know that this is a good routine measure for someone with mild dizziness, but this one does not impact bleeding risk. So you have to focus on the thrombocytopenia right now, but not about the orthostatic changes. If you selected instruct on low fat, low triglyceride diet adherence, we know that this is important but not urgent. Now at this point, the patient does not have any signs of pancreatitis recurrence. The patient has stable enzymes, so you can leave this to the discharge planning or dietitian support because this one doesn't address the clinical threat of thrombocytopenia right now. For the parameters to monitor, we need to have two correct ones, and the options are pain level using numeric pain rating scale, blood glucose levels, orthostatic blood pressure measurements, platelet count trends, triglyceride levels, signs of bleeding. The correct answers here include the platelet count trends and the signs of bleeding. Now, what we need to do is to closely monitor the platelets to check whether the patient is improving or deteriorating. And we can do this by checking daily or maybe twice daily, which will help us determine if there's probably a need for blood transfusion and maybe other interventions. And this is really going to help us mark stability in our patient's circulation. Now, signs of bleeding could be pertaining to the petechiae that would be increasing, mucosal bleeding, hematuria. And so if we're going to do this, these are going to help us in determining if bleeding is getting worse. So we're going to check for the patient's skin, their stool, their urine, their what else? Their eyes, their ears. These are all essential to monitor for a low platelet count, and we definitely need to do early detection here to prevent major bleeding event. Now, if you selected pain level using the numeric pain rating scale, the current patient's pain is around 2 out of 10, and it does not correlate with a bleeding risk. So this is something that we should still assess, but it's not something that we can track intensively right now. The bleeding is something that we should focus right now. If you selected blood glucose levels, we know that their glucose is not that skyrocketing at the moment. It's within the target range. And if the patient is newly diabetic or in insulin, you don't really, unless if they are new diabetic or if they have DKA, you don't really need to prioritize the glucose monitoring right now. Okay. Now, for the other one, orthostatic blood pressure measurements. This is also important, but this is already ordered. It's being followed. You already performed this. It's helpful, but it's not critical for monitoring the bleeding in this patient with thrombocytopenia. It's not pointing to that complication. Lastly, we have triglyceride levels. This is not urgent. And this is something that you can revisit at a later time when the patient is more stable and if they're able to receive nutrition, education, and long-term lifestyle support. And so this is the end of our Q&A today. We hope that this session boosted your understanding in managing complex patient cases and tackling next generation NCLEX test items. So I want you to keep practicing so that you'll be ready to shine on the NCLEX. Now, don't forget to subscribe to our YouTube channel for more NCLEX prep content. Give this video a thumbs up and share it with your study buddies. I'll see you in the next review session. Stay focused and keep pushing forward. Thank you for watching.